Good evening, everybody. I'll take use of that slight lull in the volume. Friends, colleagues and honoured guests, good evening. I'm Professor Warren Turner and I'm Pro Vice Chancellor for the Institute of Health and Social Care here at London South Bank University. This evening I have the rather lovely job of welcoming all of you and to introduce the inaugural lecture of Professor Susie Sykes. Before I formally introduce Professor Sykes, a little first about the nature of an inaugural lecture. An inaugural lecture is a new professor's first opportunity to formally present to their peers and the public to demonstrate their contribution to their discipline and the journey they have taken to reach the highest academic position. Universities host them to celebrate with the wider academic community and society the achievements and esteem of their professorial faculty. An inaugural lecture is therefore a significant milestone in every professor's career, and we are here this evening to hear more about the contribution of Professor Sykes' work, its impact, and on the journey that Susie has taken to reach this point in her career. At the end of Professor Sykes' lecture, as is traditional with inaugural lectures, there won't be questions and answers from the audience, but do, however, feel free to approach Susie at the reception afterwards with any questions or comments on her lecture. At the end of Susie's lecture tonight, Rachel Picton, Dean of the School of Allied and Community Health, will present a vote of thanks on behalf of the university and us all. Professor Sykes may be well known to most of you, and it's wonderful to see so many friends and colleagues here this evening. She's joined tonight by her husband, Stephen, and many of her current and former colleagues and current and former students. Welcome to you all. Before I invite Professor Sykes to present her inaugural lecture, I'll just take the opportunity to share with you a brief introduction to Susie's career so far. Susie is Professor of Public Health and Health Promotion here at London South Bank University's Institute of Health and Social Care, and she's held academic positions at both University of East London and De Montfort University before, and posts with several statutory and voluntary sector public health organisations. Following completion of her undergraduate studies at Sheffield University, Susie progressed to complete a Master's in Health and Community Development from De Montfort University, and she completed her PhD here at London South Bank University. Susie combines all three elements of the LSBU academic framework with excellence. She teaches research methods across the Institute at master's and doctoral levels and leads the Institute's Public Health Practitioner Development Programme, with demand growing significantly for both programmes. She is the director of the cross-school NIHR-funded First South Bank Evaluation Centre, which is one of 6 national centres set up to evaluate locally led, traditional and non-traditional public health interventions. This centre provides an important opportunity to co-produce evaluations within the local areas and to ensure the findings drive change both at local and national levels. Susie is former co-chair of the Population Health and Prevention Research Group and chair of the Institute's Systematic Review Board. She's committed to workforce development, working closely with partner organisations, including NHSEI, Public Health England, OHID and UK PHR, in researching the needs of the public health workforce. She's also been part of several projects to develop masterclasses to support public health practitioners towards registration. She's an approved assessor for the UK PHR Public Health Registration Programme and is a senior fellow of the Higher Education Academy. Susie's main area of research interest focuses on health literacy, a field she has published widely in. Recent projects examine e-health literacy for people experiencing infertility and e-health literacy in a pandemic context. She also researches community-focused public health intervention evaluation, and workforce development. Susie is a member of several international collaborations, Vice Chair of the IUHPE Global Working Group for Health Literacy, and is part of the Global Health Literacy and COVID-19 Consortium. She has participated in teaching and research partnerships with Southeastern University China, Bielefeld University Germany, and the University of West Indies in Trinidad, and with partners across Europe. The overwhelming consensus from those who work with Susie would be that she always goes above and beyond, both professionally and to support her colleagues. Her close colleague, Professor Jane Wills, here this evening, says Susie has such a nice way about her that manages to enable her colleagues and students to really get the best out of themselves. She's one of those rare staff who combines every element of our academic framework as an educator, a researcher and a leader, and demonstrates all those professional behavioural values. She's excellent and professional with high expectations for herself, always acts with integrity and communicates her expectations clearly. Honoured guests, ladies and gentlemen, I'm delighted to invite Professor Susie Sykes to present her inaugural lecture entitled Public Health, The Bigger Picture. Susie.
Thank you, Warren, for those kind words, that introduction, and Jane for your contribution. Stop me crying before I start. That was really kind of you. So thank you all as well for coming along tonight. It's wonderful to see so many familiar faces in the audience, so thank you. And I hope that you'll enjoy some of my reflections on my work, and I do hope that you'll join me afterwards in conversations about that. I'd really look forward to that. Someone said to me yesterday that an inaugural lecture doesn't count as an inaugural lecture if it doesn't have an early career photo and a bad joke in it. I have got the photo. I haven't got, I hope, a bad joke or a good joke, but I hope that you'll enjoy it nonetheless. Okay. So I'm going to be talking about my work and career in public health. Public health, many of you will know, is a very broad discipline. It has multiple goals and multiple approaches, which makes for a really interesting career, a varied career, but does then present challenges in trying to decide what to talk about in an inaugural lecture, and which bit of that work and that career to focus on. So in thinking about how to approach this, I've decided to talk about themes. So I will spend a little bit of time just reflecting on my early career and thinking about what it was that influenced me in setting the priorities for my career as I've gone forward. I know that some of you here do work in public health, but for those of you that don't, I'm going to do a little bit of scene setting and talk about what we mean by public health, and reflect a little bit on the opportunities that I think that the field gives us, and also a reflection on sometimes where we miss those opportunities. Then I'm going to dig down into one particular area of my work that I think exemplifies these opportunities and missed possibilities, and that's going to be around health literacy and my research there, which Warren has mentioned. And as an educator, as well as a researcher, I also want to talk about the workforce and the work that we do and the work that needs still to be done to equip the public health workforce in meeting some of these challenges. And then I'll just conclude by thinking a little bit about the exciting future that I think we have at LSBU in building ourselves as a centre of excellence in public health. So that's the plan for the next hour. There's the photo, we'll get that over with quickly. But just reflecting back on my early days, as Warren said, I did my first degree at the University of Sheffield, and as for many people, that was the springboard for my career. But I read history at Sheffield, so it wasn't so much the course that kind of acted as a springboard for my career, although it gave me many useful skills. It was the extracurricular work that I was involved in that was important. I did a lot of work with the communities and women's sabbatical at university, and did a lot of work, voluntary work, and work with different community organisations as a student. And it was really that inspired me and directed me in terms of my career goals. And it led me to my first kind of full-time job, which was working for Turning Point, a voluntary sector organisation in Sheffield, to set up and lead a young people's drugs project. And these pictures are of me there in my slightly hippier days, giving out harm reduction drugs advice at music festivals in Sheffield. And you can see there my trusty old British Telecom van that followed me around as I travelled around Sheffield doing this work. And it felt like a real opportunity to make a difference and to make a difference to young people's lives. And I think we did make a difference, I really do. But it definitely came with some frustrations and left me feeling that there was more that needed to be done. And there were two lads in particular that have always stayed with me. Well, they haven't stayed with me literally, but their memory of them has stayed with me. That was my bad joke. That's got that done. But they made an impression on me. They really did. One of them was a lad called Craig. We were doing a series of workshops in a youth centre on the outskirts of Sheffield. And we were operating from the principle of harm reduction. So we were providing accurate information so that people could make informed decisions. And Craig was a regular user of marijuana. He didn't need any more information. His knowledge was accurate and comprehensive. But I remember talking to him afterwards outside the youth club and him saying, everybody wants to talk about my drug use. Everyone wants to talk to me about why I smoke weed. He said, but that isn't my problem. He said, the things that are going on in my lives other than that is my problem. And he described his kind of home life. He described that his father was an ex-miner and had been unemployed for a long time, had an alcohol problem. He talked about his mother who worked long hours and different shifts and wasn't present at home, an older brother who was in prison, and an education that he clearly felt disengaged from and felt that they had disengaged from him. And he said, these are my problems. And I kind of, he didn't understand why we all wanted to talk about his drug use and not that. And the other lad was John, and he was Craig 4 years down the line. He was 21, slightly older, and he, when I met him, he was no longer a recreational drug user, as Craig might have been described, but was a chaotic and dependent drug user, with alcohol being his main alcohol of choice. Substance of choice. But he described a family situation very different, very similar to that of Craig's. But those family networks had now broken down. He no longer had that community support and was essentially on his own in the world. And during the time I worked with him, he was arrested and went to Doncaster prison. And these are just photos of letters that he sent me that I've kept from Doncaster prison, which I read recently, reread recently, and they were funny, reflective, kind, but striking in their lack of hope and lack of aspiration for the future. They also included a maths worksheet that he optimistically hoped I would complete for him, that the educationalist had sent to him. But they were very sad to read. And it felt from these two experiences and many more people that I worked with that there was a revolving door of Craig and John's, and it kind of felt so inevitable that there would be more and more Craig and John's. And while their individual stories were so important, there were shared characteristics across the community. And it left me reflecting that actually we shouldn't just be thinking about individuals. Those individual stories are important, but we need to be thinking about the characteristics and the issues across a whole population. It left me feeling that we shouldn't just be thinking about these symptoms. They were with me because of their drug use, but actually it was the causes that were more important for us to think about. And that while I was talking to them about their drug use, someone else was talking to them about their mental health, someone else was talking to them about their poor physical health, and yet all of these health problems stemmed from the same root causes. And it was these causes that were of interest to me. And the other thing that struck me from the work that I did there was the power of the communities that they lived in, particularly for Craig. John had lost contact with a lot of his community, but for Craig, the resources that he drew on most were those resources that were provided at a community level, those volunteer youth workers that provided not only a buffer for him, but that were an important resource who understood the issues that he was facing and knew best how to deal with those issues. So I made a decision to kind of transition from that individual service provision into public health. And I know that there are lots of people in the audience that work in public health, so apologies that this will be familiar territory for you, but I think it's important just to kind of reflect on public health and what it is that we're trying to achieve. So this is a definition of public health that is well rehearsed and well used, and rightly so, because it kind of captures some important elements of public health as a profession. So it talks about public health as being both a science and an art, and that kind of captures the multidisciplinary nature of public health. That public health is a field in its own right, but that it also draws across disciplines. It draws on the natural sciences, it draws on the social sciences, it draws on education, it draws on psychology. So it brings together a whole range of disciplines. And that it talks about prolonging life and promoting health. So public health is about prevention, it is about preventing ill health, but really importantly, it's about promoting well-being and good health as well, and that's a different and important distinction. And then finally, that it talks about that we do this through the organised efforts of society. So the work of public health is not about any work of any individuals or any individual organisations. It's a collective effort, and it's a collective effort that needs to be addressed across organisations, across professionals, and also with the engagement of the communities that we are working with. So I made this transition into public health, and Warren's nicely captured my kind of journey through public health. And I spent nearly 10 years working in health promotion teams in Bromley and in Croydon, working as part of a health promotion team with young people and as part of a teenage pregnancy team as well. But having done my MA in health and community development, I was really attracted to the research side of things, and increasingly incorporated a research and evaluation element into my roles, and was able ultimately to kind of move to a part-time position and accompany that with work on a part-time basis in academia within the University of East London and De Montfort University. So that was really nice to be able to kind of straddle both. But eventually decided to make my home in academia by coming here to South Bank University 18 years ago, which I can't quite believe it's been that long. Initially part-time, which gave me a really wonderful opportunity to continue work in practice and work on a freelance basis with a number of different public health organisations. And since I've been here at LSBU, I've had the opportunity to undertake a number of different roles. So, like for many people, it's been a juggle between different roles while also studying and also juggling with a few babies in between as well, which they won't appreciate being represented like that, but they didn't come, so there we go. So that kind of just takes me to the point where those early experiences, those early study that I did and work that I did have kind of brought three themes together for me that have kind of been with me throughout my career and that I want to thread through the rest of my talk tonight. And so the first of those is the importance of working at a policy level, at a political level, working at the level of addressing causes as well as the consequences. Secondly is the importance of the role of communities in that and their ability to identify their own needs and address those needs, and our need to kind of capitalise on that where we can. And then thirdly, the importance of having an equipped workforce in place in order to achieve the potential that public health offers us. So those are the three things that I took from my early career and that I will thread through the rest of my talk tonight. but also a frustration, really, that within public health we still do default back to individuals rather than populations, and we default often to behaviours rather than causes. And so that's another reflection from those early days. So just to walk through a little bit more about public health, it appealed to me as a career because of its focus on causes, and because it foregrounds those wider determinants of health that are so important in influencing our health and well-being outcomes. And these wider determinants of health refer to those social, economic, cultural, environmental, and importantly, commercial factors that influence our health and well-being outcome. And this model on the left here, many of you will be familiar with, from Dahlgren and Whitehead in the 90s. There's been many versions and updated kind of versions of it since, but it remains an important model. And this kind of captures how the various levels of influence on our health outcomes, from those individual factors at the centre, moving outwards to include those social and the factors within our social and community networks that influence our health and well-being, and then those factors in our living and working conditions, so our housing, our transport, our employment, our built environment, all those factors influencing our health outcomes that sit within a wider general socioeconomic kind of set of circumstances within our world. And if we translate that into a causal pathway, we can see that disease that occurs, may happen for factors to do with your genetic or physiological dispositions, but have risk factors that may often sit within what are often wrongly labelled kind of lifestyle factors or behavioural factors, but that those factors have their own causes, and that the further that you move up this kind of causal pathway, looking at the causes, the more we move into political and social realms that the individuals themselves have very little control over. So what did this causal pathway look like for John and Craig? John presented with psychotic episodes and depression. That's what he was referred for. But what caused that? Inevitably, there may well have been some physiological or genetic predispositions to that, but importantly, it was his polysubstance use that was a trigger, so that might be called behavioural factors or lifestyle factors. But what was the cause of that? So if we move back into those community networks and those social networks, he was coming from a context of broken family relationships, normalised group peer behaviour. And what were the causes of that? We move back again then into the living and working conditions that he grew up in and spent his early life in. One of family unemployment, homelessness, a history of family offending. And what were the causes of that? You move back and look at those socio and economic conditions of the world that he was born into, and it was an area of socio-economic deprivation, with a very poor educational offer, poor employment prospects, poor housing, poor transport. You can imagine the scenario. And that's not to say there wasn't any personal agency, that there wasn't any personal responsibility or any choice, but the odds were stacked against him. And had he been from an ethnic minority group, he would have experienced layers of oppression and discrimination at each of those stages that would created even more barriers and impacted even more on his likely health outcomes. So you see this typical depiction of the upstream-downstream model. Are we pulling people out of the river once they've fallen in, or are we thinking more upstream about when people fall in the first place? And people experience these determinants of health differently. Individuals experience them differently, but communities experience them differently as well. And because people experience those determinants of health so differently, that leads to inequalities and inequities in health. And just some figures here that demonstrate that very stark differences in life expectancy that we have according to, depending on deprivation. with people living up to 20 years more or less, depending on where they're born. And that's not just about life expectancy. This, the slide, the graph on the right there shows the very stark differences in quality of life indicators according to ethnicity there. And I was working with John and Craig in the 90s when inequalities in health were beginning to shrink. But we know now that we're in a situation where those inequalities are growing again. And that is of concern for us in public health. And not only are they growing, but they're growing disproportionately, so that those inequalities are affecting some communities far more than others. And we see that life expectancy itself is slowing in its growth, and in some areas is actually decreasing. And it's as you can imagine, it's very difficult to measure the impact of those wider determinants of health. But those that have tried have come up with similar figures to these that are produced by the University of Wisconsin, which shows that those health behavioural factors can be said to account for 30% of a contributory factor towards our health outcomes, and clinical care 20%. So providing those support services and those treatment services is so important, but it needs to happen alongside addressing the socioeconomic factors and the physical factors, the physical environment factors, which can be said to account for 50% of our health outcomes. So public health enables us to address across these different realms, to work at that individual level, to address those behavioural factors, but also by working across policy areas to address those social and economic factors as well. And it's that's important for public health. So there's a strong case to be made for a focus of public health on prevention and on working upstream. And public health offers good value. I'm not here to sell public health, or maybe I am, but it does offer us good value. So for each additional year of good health achieved by public health, that costs $3,800 compared to $13,800 when delivered through NHS treatment services. So there's a very good economic case. And yet we see the public health grants at a local authority level having been cut by 21 to 26% since 2015. So a really significant real-term per person cut in investment in public health. And that hasn't happened evenly across the country, so that those most deprived areas have seen an even bigger cut, so up to 33% in some areas. And this graph here comes from the Health Foundation, and part of a presentation they did recently, where they put forward a case that the government is not investing in prevention. And this slide shows that the biggest government budget increase has come within health and social care, but the vast majority of that budget increase has happened in treatment services. And that these other budget areas that deal with housing, education, and so those factors that are possible, where it is possible to address those wider determinants of health, have actually had a significant cut in budget. And it's in those areas that public health can work alongside those other departments in order to address those wider determinants of health. So we're not investing in this work. Instead, we see this kind of constant default back to a social narrative of individual responsibility and the need to address individual behaviours. And the policies that we see come out centrally focus on that prioritisation of individual behaviour change interventions, which are important, but need to sit alongside that work more upstream to address those determinants. And it's perhaps not surprising that we see this default back to individual responsibility. It's really hard to prioritise that upstream agenda. It requires us to work across policy domains. It requires us to work interprofessionally, and that's a difficult task to achieve, and it's difficult to get health on everybody's agenda, which is what this kind of approach requires. It's difficult to measure the impact of that work, and that impact won't be seen immediately. It takes a lot longer to see impact. You see impact much quicker by working downstream. And that also there is this kind of cultural emphasis on individual responsibility and the need for choice, that we should be free to make choices about our health. And also a kind of a political, ideological position that encourages this individual responsibility emphasis. The kind of the political decision not to want to be seen as a nanny state. And that also there is an encouragement of this focus on individual responsibility. I talked earlier about the commercial determinants of health as being increasingly understood as being an important determinant of health. So the commercial determinants of health being those factors that where the private sector and commercial and industry influence our health outcomes. And for many people in the research that's come through recently has demonstrated how industry itself encourages this focus on individual responsibility because it doesn't want that state intervention. So having reflected a little bit on where I see the potential of public health and some of the frustrations at the movement downstream rather than upstream and the focus on individuals rather than communities, I want to talk just a little bit more about health literacy, which has been a focused area of my research, as a kind of an example, a case in point as to where how these frustrations and opportunities can be seen. So health literacy is an area that has received a growing amount of attention. You can see here on the right, this slide here shows the number of publications that have appeared in the Web of Science since 2003. So you can see there's been this real growth in attention to health literacy. And the definition that I put up here is definitions of health literacy have changed a lot over the last kind of 20 years, but this is a current definition that comes from the World Health Organization. And it reflects that health literacy refers to those skills and competencies that are held by individuals and communities as they seek to access, understand, appraise, and use information and services, to use health information and the services that are available to them. And it emphasises the fact that these skills and capabilities are mediated by the organisational structures available to them. So while it refers to the skill set of individuals, it recognises that the health literacy that we have is mediated by the complexity of the environment that we're trying to navigate. So that it's not just about an individual, it's also about their environment. And there's a large body of work that identifies the link between health literacy and health outcomes. So the World Health Organization have identified health literacy as a key determinant of health. So we know that those people with low levels of health literacy are more likely to be hospitalised, they're more likely to use emergency care, they're less likely to use screening services, to self-manage, be compliant with their treatment, and generally more likely to have poorer overall health status and higher mortality rates. And some of the work from the World Health Organization has pulled together has concluded that health literacy is actually a stronger predictor of poor health than age, income, employment, education, and so on, although the relationship between all of those factors is closely intertwined. So health literacy is a determinant of health, and worryingly, given that, studies that have sought to measure levels of health literacy have shown that in Europe, 50% of adults have either problematic or inadequate health literacy. And a recent meta-analysis showed that 1 in 3 to almost 1 in 2 of every Europeans may not be able to understand essential health-related information. So it's an important area to understand. But what I want to kind of focus on is the fact that most of the attention that has been given to health literacy has been a very narrow definition, or a narrowing of the definition of health literacy. And I just want to spend some time flagging why I think that's problematic and how some of our work has reflected that. So if you go back to this definition, you can see that the focus of work and of practice development and policy development has interpreted health literacy by focusing on the personal knowledge and competencies that enable people to access, understand, appraise and use information. So as a very kind of linear process. And this is referred to as functional health literacy, and it is important. But there is a danger, I think, in narrowing the definition of health literacy and focusing on this part of it. Subsequently, there has been an increased focus on the organisational structures and availability of resources. So this kind of refers to and recognises the point that I made earlier about the need for environments to be health literate friendly, and that there's a responsibility there. And we might refer to that as interactive health literacy. And there's now a growing body of work that looks at the health literacy of professionals in their ability to respond to the health literacy needs of the people that they work with. But two elements that have received less attention in the research, and which have been the focus of our work, has been on two elements of the definition that I just want to refer to, because I do think that they are important, that they don't get missed. So the first is then the social interactions across generations. And this is important because this is the bit that reflects and emphasises the fact that we don't use information on our own, that we do so as part of our networks, we do so as part of our communities, and that those social processes that are involved in accessing, understanding, appraising and using information are important. And that secondly, the bit at the end about those around them, that not only are people using information for themselves, there is the potential to use it for the benefit of the wider community and to move upstream and address those wider determinants of health through a health literacy approach. And these two domains that kind of fall within this definition, we might refer to as critical health literacy and distributed health literacy. And I want to talk a little bit more about them and some of the work that we've done around that. So one of the neglected areas of health literacy, critical health literacy. And this was first presented by Donald Nutbeam as part of a tripartite kind of approach to health literacy, where he talked about functional health literacy, interactive health literacy, and critical health literacy. But critical health literacy was the least well defined, it was the least well understood, and as a result, it's been the least well applied. And work that we did back in 2013 sought to develop the understanding of critical health literacy and offer a kind of a conceptual framework for critical health literacy. And that work has remained influential in informing and underpinning much of the work subsequently around critical health literacy. And the work that we did conceptualised it and presented it as an important domain of health literacy that included within it a number of different attributes. So within that definition, we can see that critical health literacy is those higher order cognitive and social skills that are important in people understanding complex health information, but importantly being able to contextualise it and apply it to the context of their own lives in order to use it to make decisions. but that also it comes with a set of skills about being able to critically appraise information, to assess the credibility of information and assess its relevance. And that is clearly important in a time where we are surrounded by complex information, but also misinformation. But that thirdly, it has, as part of critical health literacy, the understanding and the fluency, not only in health information, but in the causes of health outcomes and in those wider determinants of health. So an understanding of the wider determinants of health and within that, a commitment to action for change, action for political and social change. So it takes the definition of health literacy, it broadens it, and it shifts our thinking upstream again. And importantly, critical health literacy was conceptualised as something that exists not only at an individual level, but as a resource that exists across communities. And that links in with distributed health literacy. So distributed health literacy is a related concept which positions, which kind of posits that health literacy isn't something that people use in isolation, but that actually when people use and make sense of information, they do so amongst their social networks. They draw on the knowledge and skills of those around them as part of that process of sense making, so that that linear journey within the definition needs to be understood within our social context. And this is really important, particularly in areas where people have low literacy level, that it brings in that element of conversation and information spread by word of mouth. And we know that distributed health literacy as a resource is important as a buffer against the adverse impacts of low health literacy. So it starts to see health literacy not as an individual skill set, but more as a form of social capital that exists within communities that individuals can draw on as and when they need to. And these two dimensions of health literacy are really important. They sit alongside the functional health literacy. They don't undermine the importance of that, but they complement it. And they enable us to see health literacy as a community asset. So less as an individual deficit and more as an asset that exists within communities. And they include this recognition of health as being determined socially and politically. And they move people away from individual action and individual choices to those of collective action. And we've done a lot of work as in looking at these two dimensions of critical health, of health literacy, in order to understand how they're applied and how they are, what the domains mean, but how they are applied and how they can be developed. And that's kind of formed the basis of a lot of our work. And review work that we did looking at how critical health literacy is studied, how it's applied, how it's developed, how it appears in practice, has shown that there is again this kind of narrowing of understanding of critical health literacy, and that often the political action element of critical health literacy gets lost, and that it often defaults back to being seen as simply the critical appraisal of health information. And there's lots of reasons why that happens. It's difficult within practice to develop that political agency, that action for change that is incorporated within critical health literacy. It's a complex concept. It's difficult to measure. And therefore, the kind of default back to the functional health literacy becomes attractive. But what we have been able to show through our work is that where critical health literacy is most successfully developed, it's done through participatory participatory approaches that are based on a critical pedagogical approach through a cycle of working with communities to identify issues of concern, to reflect on and explore the causes of those concerns, to engage in a dialogue about the causes of those concerns, and then promotion of political agency, of action to address those issues. And just to kind of bring that to life and kind of show what that means, this is from a piece of case study research that we did that showed how these participatory approaches, these participatory deliberative processes can lead to critical health literacy across a community. So this was a project led by Our Life. It was called Talking Food, Taking Action, that we included as part of our research. And this was driven by the obesity agenda, by a kind of a public health goal of achieving healthy eating. But rather than focusing on the behaviours of individuals or on the skills of individuals or the knowledge of individuals to encourage healthy eating, it shifted upstream and worked with a community to create a vision of a healthy food environment. So by working with the community, using those principles of a critical pedagogical approach as influenced by the work of Paulo Freire in the 60s and 70s, they went through a process of working with the community to identify with them what the barriers to healthy eating were, the barriers that they experienced while living in this community. And having identified those barriers, they worked with them to reflect on what are the causes of those barriers. And in doing so, they were able to identify the organisations, the people, the stakeholders, those with power that reflected part of those barriers. And the organisation worked to bring the community into contact with those stakeholders to engage in a reflective dialogue with them about why those barriers existed. So they talked to the planning department about why there were so many takeaways in a particular area. They talked to the housing association about why there was a kind of contractual arrangement with only one supermarket in that local area. They spoke to that local supermarket to ask them why the fresh fruit and vegetables that they provided cost more than they did in the same supermarket in another area. So they had those conversations in order to understand better why those barriers were existing, but also how they could potentially be removed. And from that, they moved into a stage of action where they as a community prioritised those barriers and the changes that they wanted to see, and that they worked towards those changes. So they implemented some changes themselves, introducing schemes like a food box, local cooking classes, but they also worked with those stakeholders to remove some of those barriers. So they worked with the local planning department to work with the takeaways to look at how a healthier option could be included within the menus. They lobbied government where they could see that some of those issues around healthy school meals were coming from a central level. So you can see it's a really great example of critical health literacy. They became fluent in the causes of their poor health outcomes, and they became agents of change in addressing those. And again in our work, we've seen the importance of health literacy as a social resource. Lots of our work has demonstrated how people engage with members of their social group, members of their community, in addressing, as part of that health literacy process. So work that we did in Trinidad was typical in demonstrating that. So I've already said that health literacy is mediated by the environment that you find yourself in. And in this work we did in Trinidad, we could see that there were particular barriers created for men in achieving high health literacy because of pervasive social norms and expectations around sickness and kind of norms of masculinity and expectations. And where these barriers that were in place to their health literacy, we saw that their family and partners became really important buffers, again, to that low health literacy, but a resource to compensate for those challenges of health literacy. And if we think about communities as an important resource for health literacy and see health literacy as a form of capital that exists within our communities, we have to recognise that increasingly communities exist in online spaces as well as within the real world, if we can make that distinction. And so we need to think about what those communities look like in the virtual world, those virtual communities and their contribution to health literacy. And prior to the pandemic, we did some work looking at infertility and accessing health information for people experiencing infertility. And what we saw from this work was that there were three important sources of information for people as they sought to navigate their journey. There was the web-based information that people drew on. There was the interactions with health professionals, so health professionals remained a really important source of information, but it was the virtual community to which they continually returned, and that was a really important resource, and that they used this online space, to the online community, to access that information, access additional information from people that they trusted within this space. But importantly, they used that space to go through a process that helped them understand and make sense of that information. So the conversations that took place in that online space were sense-making spaces. And that they also used it to test out credibility, to check the credibility of the sources of information, and they used it to rehearse their decision-making, to practice their communications that they were going to then take to the health professionals. So this space was a really important space for them, and they returned to it again and again. That was particularly so in the context of infertility. And I said before about the different contexts in which health literacy manifests. And that in that context, we heard particularly that this was an issue that people felt was surrounded by stigma, and that they couldn't talk as freely to people that they knew closely, their family and friends, and therefore the anonymity of these online communities became really important. And work that we did during the pandemic also looked at how people used these online spaces to make sense of information. And again, it was identified as an important resource. So understanding these processes is really important for us in public health. Understanding how people make use of each other as they go through this journey of accessing, understanding, appraising and using information is important for us in public health. And it's particularly important because it comes with a danger of that information being incorrect or there being misinformation or disinformation within those spaces. But it also creates a really important opportunity for us in public health to target work and to build those skills across a community. And credibility in all of those studies that I just talked about, or credibility of information, was seen as really important. People prioritised the credibility of their information, but they identified very real challenges that they faced in assessing credibility of information and trustworthiness of information. But what we see from the processes that we've explored is that social interaction in the use of information was successful in moving people from being seekers of information to becoming purveyors of information. And we saw that particularly in that study around infertility. And understanding that is really important for us in public health if we want to influence that journey. And returning to my earlier point that health literacy is context specific and mediated by the health literacy of the environment in which people find themselves, understanding the health literacy of health professionals is also a really important part of the work. And work we did during the pandemic looked at the digital health literacy of students. And this was part of a study with 50 other countries, and we led the English arm of this study. And one of the things that we discovered through the work was that the digital health literacy of healthcare students was no better than the digital health literacy of non-healthcare students. And that might feel like a slightly counterintuitive finding. And that also the digital health literacy of healthcare students didn't improve through their academic career. And that slightly worryingly, the healthcare students relied less on official public sources of information about the pandemic than their non-healthcare student peers. So this was just one relatively small study and a small part of a wider study, and we'll see in the future how the English data compares to that was coming from the other countries. But clearly there's work to be done on ensuring that the professionals that work with people with low health literacy are able to create that appropriate environment. So, thinking then about what this means, the World Health Organization has identified health literacy as a determinant of health and as an important strategy in meeting the needs of the most disadvantaged communities and in achieving the goals of the 2030 Agenda for Sustainable Development. And within this ambition, they identify that health literacy offers us the potential for community action for health, and that it offers us the opportunity to push governments to meet their responsibilities in addressing health and health equity. But if we want health literacy to be part of that and to achieve that, we need to think about functional health literacy alongside those other domains of health literacy, distributed and critical health literacy, that enable us to think upstream and work across communities. So, having reflected a little bit on the need to work upstream and to work and engage with communities in collective action, it's really important to think about the challenges that this creates for the workforce. These are difficult challenges. And Warren mentioned that we have a FIRST centre at LSBU, and some of the work that we've done through the FIRST centre has enabled us to get a better understanding of some of the challenges that face the workforce. So we were awarded the first contract in 2020, initially one of 4 centres that were put in place in order to support the evaluation of locally led public health interventions. And we are there to co-produce evaluations with those local stakeholders and to help answer questions that are useful for local decision making, but that are also important in filling part of the gap in the evidence base that we have for public health. And I see many faces in the audience who've been involved in work that we've done as part of the FIRST centres. So this is very much a team effort. But we've so far been given 9 different projects to evaluate. You can see them here. And not only are they spread all over England, but they cover a really wide range of different subjects. So we've had projects looking at exercise, around smoking, around substance use and alcohol use, around youth violence is our latest project, mental health, a whole range of different projects. And many of those projects are about working with individuals, but many of them have an element of or are dedicated to pushing upstream and addressing some of those determinants of health. So we've got a project in Greater Manchester looking at communities against gambling-related harms. And Tom Mills is leading a lot of that work. And what they've been looking at is how communities and those with lived experience of gambling have been able to be part of a community-based project to challenge some of those industry controls over the gambling environment. And it's a really excellent example of how critical health literacy can be capitalised on in order to address and influence change. But with that comes some real challenges. So just looking briefly at one of the projects that we had, the first project that we were allocated was to look at a region of England that was working to try and restrict the advertising of products high in fat, salt and sugar across a region. So there were 12 local authorities seeking to make change. So this is an example of a public health initiative that is seeking to work upstream, to trying to create an environment that is more conducive and makes it easier for people to eat healthily. And we know from where this has been done in London that by restricting the advertising of HFSS products on the London transport system, that has resulted in reduced purchasing of sugar and, in particular, confectionery products. So we know the evidence is growing. But what we saw through our work across this region, in the 12 months that we collected data on this, none of the areas were successful in implementing this policy change. They achieved a lot of things. They achieved a lot of engagement from stakeholders. They achieved an increase in political will for the change, and some areas had draft policies in place. But it was an important finding because what it shows is the length of time that it can take to affect policy change and the amount of input and commitment that is required in order to make that change at that level. And we were able to capture this logic model kind of captures a lot of our findings in terms of the strategies that they used that were successful in doing that, some of the barriers and facilitators to that they experienced in that work. But one of the things that was most important in that work was the policy advocates themselves. They were the most important resource. So these were the public health leads from each area, public health practitioners who were leading that policy change process, who had responsibility for the work in that area and were driving the change forward. These were the key resource, but when we spoke to them, what we learned was that they felt poorly equipped for that task. They felt that it was different to other public health work that they were doing, more project-based public health work. They felt that they hadn't received the same training in this strategy, and that they felt that it was a very complex role, and that in some ways they didn't have permission for that role to lobby elected members for a policy change that they didn't necessarily come into office with a kind of a manifesto to deliver. So there were some real challenges facing these policy advocates, and I think that's one of the lessons from this study is that we need to equip our workforce so that we can ensure that work is undertaken to support those people downstream, but to also stop them falling in upstream. And I think we're proud of the work that we've done in LSBU in building the workforce. So we had an MSc, a Master's for many years in public health and health promotion under the stewardship of Jane Wills. And that was the course that I came into LSBU to teach. And it was a really successful program that has led to students, some of whom are here today, taking on important and interesting and diverse roles within the public health workforce. The public workforce needs have changed and we no longer offer that program, but what we offer instead is a commissioned programs of workforce development, continuous development programs. And we work closely with the Health Education England to identify the needs that public health practitioners have. So there's a specialist route that the workforce can go down, supported by the Faculty of Public Health, and that will result in specialist registration for public health. But practitioners working at a practitioner level have the opportunity to work towards a voluntary register. And we worked with the Health Education England to identify the support needs for that particular part of the workforce. And we now offer a series of masterclasses across 6 regions that support public health practitioners towards registration. So there's lots of exciting work that we're doing, and we continue to do that work, and we continue to look at what the educational offer needs to be and how we can continue to respond to those workforce needs. And I do think that the future of public health at LSBU is exciting, As I say, we continue to look at how we can make sure that the workforce is equipped. The work that we have done to pull together the first centre has been really exciting opportunity. And we've worked really hard to build an infrastructure that recognises the interdisciplinary nature of public health. So when we put in our bid to become a first centre, we did so on the basis that if we were going to be evaluating initiatives that across the policy realm, across those determinants of health, we needed to have academics with specialist knowledge of public health, but we also needed to have academics with a knowledge of psychology, of education, of sports science. And we have a really true collaboration, I think, of 5 research centres in delivering the first agenda. And I think that's really important to capitalise on as we think about how we can take advantage of the future opportunities that we have to build that. And I heard today from NIHR that there will be an opportunity for us to rebid to continue our contract as a first centre if we want to. So there's some important conversations for us to have about how we take this work forward. And the first centres were one part of NIHR's new prioritisation about ensuring research at a local level for public health. Another strategy that they have in place are health determinant research collaborations, HDRCs. And this is an initiative that will be led by local authorities, but in partnership with academic partners. And we're excited to work with one of our local boroughs in applying to have a HDRC locally. And we look forward to, again, building on those opportunities. So that brings me to the end, really, of my reflections on why I think public health is so important, why it offers so many different opportunities, but why I think we also need to keep our eye on that bigger picture to ensure that we make the most of the possibilities that public health offers us. But before I finish, I just want to say a few thank yous. None of this work that I have done has ever been on its own. It's always been part of a team. And I would really want to emphasise that I have huge gratitude to express to many, many people. But there are just a few people that in this strange process of writing an inaugural lecture where you reflect back on your career and think about the people that were influential in it, there are just a few people that struck me as being influential and important. And I just want to say thank you to those people. So the first person that I just would say thank you to is someone, Chris Anderson, who I worked with back in Sheffield, where he was a schools advisor and worked in the health promotion department there. And it was he really that introduced me to public health, or specifically to health promotion. And many conversations in those earlier days about those kind of frustrations that I reflected were had with Chris. And he was really instrumental in my decision to move towards public health. And it was he that helped me secure my first position in health promotion at a time where I wasn't quite sure where to go. So he was really important to me. Secondly, Dr. Kerry Young. Dr. Kerry was really influential in inspiring me to study health and community development at De Montfort University. And she always inspired me about her belief in communities and her passion about the potential that they had to effect change for themselves. And she led a module at De Montfort where I did my MA in anti-oppressive practice. And she taught me so much about oppression, about discrimination, about social justice, and about the transition of power that's needed if we want to work in a truly empowering way. But it was that was inspirational to me. But more than that was her way of working. So she taught this module with a very diverse set of students, all of whom had very different and very personal experiences of discrimination and oppression and very different views. And she managed really successfully to create a safe space for us to discuss this in a nuanced and complex way. And I often reflect in a world now where we have very, very kind of non-nuanced conversations and very polarised conversations on her skills to create that safe space. And I think we could learn a lot from that. And then finally, my last thank you is to Jane, Professor Jane Wills. I could not have done today's lecture without the opportunities that she has given me. I first came across Jane's work when I did my master's back in 1999, and it was her textbook that was the required reading. And I think it was the first time, having worked in health promotion but not studied it, it was the first time I saw what I was doing reflected in models and theories within her textbook, and it suddenly started to make sense to me. And so when I came for my interview here at LSBU and I saw her, she was on the interview panel, I was intimidated, to say the least. And while I thought that was a really interesting conversation during that interview, I didn't think I would be back. But luckily she did give me a chance, and since then has continued to inspire and motivate me as my manager at times, my doctoral supervisor, my mentor, a collaborator on so many projects, and a dear friend. And so I thank you, Jane, for all of those opportunities and for building the really firm foundation of public health that we've had at LSB and that I've been able to enter into. So thank you. And thank you all for joining me tonight.